I'm going to say some things that people claim is not true, but it is true. I'm an ear, nose, throat doctor. I don't remember your eardrum from last year. I don't care what people tell you. They don't remember 3,000 eardrums.
You don't look and go, oh, Sally,
exactly.
I recognize you.
I remember what your eardrum looks like. Yeah. We don't remember any of that.
Welcome to Self-Funded with Spencer, sponsored by Pareto Health, ClaimDoc, and PlanSight. Whether we're discussing innovative new healthcare strategies, exposing hidden revenue streams or misaligned incentives, or even just cheering on the next generation of this industry, we promise you that you're going to learn something. So thank you for joining us for another great conversation about the future of healthcare. It seems like the drugs that I've witnessed in my lifetime that had a huge splash and there was huge demand and it was a rush to market, there's always a fallout that happens, and it's usually financial and it's usually related to some lawsuit or, do you suspect that we could see something like that?
Penicillin.
Okay.
Penicillin doesn't have lawsuits.
Well, I'm thinking more in the weight loss category,
Exactly. Like fen-phen.
Fen-phen is a great example, yeah.
But the thing is, this is not like that.
Okay.
We have to be honest with ourselves of what's happening. We're like witnessing the next antibiotic. There was not a class of drugs like this. Suddenly you had something come in that went to the root of the problem. It affects obesity directly. So now it's like, okay, we're affecting obesity directly. I guess obesity was the problem this whole time. Oh wow, surprise. What people have been talking about. And if you get rid of obesity, you're getting rid of all the downstream. Colorectal cancer rates are going to go down. Heart failure rates are going to go down. Heart disease rates are going to go down. Diabetes rates are going to go down. And so it's and you have this initial set of side effects, which is muscle mass loss, and the nausea and the GI distress.
But does that level off though?
The muscle mass loss?
Yeah.
Once you hit target, yes. So once your weight loss, once you get to a steady state, yes.
Okay.
But the issue is it's really hard to put the weight back on. So you have to actually do it as you're going. Because you're actually losing not just like the muscle that you see here, but also skeletal muscle in general.
Okay.
Yeah, exactly. And so like things like stabilizers, things like that, those are really hard to build, right? Like just think about even with sports and exercise. But what's really fascinating is there's a whole new class of drugs that are going to come on board that like we are not even thinking of. Think about this being like this spawning point of all these drugs that are around solving this problem. So when penicillin came out, it didn't work for everything. It worked for syphilis, and it was great for that, but it didn't work for everything. Suddenly, you needed to also be able to take care of gram negatives and all these other types of bacteria. So you added on other drugs to like help support it. That's how you have, so, with your kiddos, when they get an ear infection, we give them amoxicillin. If that doesn't work, then we give them augmentin, which is amoxicillin clavulanate. And so it's like, okay, those two together are stronger than one.
Yeah.
So right now, there's a bunch of different companies that are working to solve that muscle mass problem. So imagine you could take a drug and not only would you lose fat, but you also gain muscle at the same time.
Okay.
That's coming less than 10 years.
Okay. So it's going to be part of that formula. It's not necessarily going to be add this other drug. I mean, so
it's going to be it's going to be add this other drug together in a combo.
Okay. Because I was telling you about the individual I knew that was using testosterone and upping the dosage, right? And it was a small bump in their dosage, and he's a middle-aged guy on TRT. That upping of the dosage didn't stave off the loss of muscle mass for him in that situation. So he was thinking I could counteract those two things, keep weight training, up my protein, yet still, I think you'd say 60% of the mass or the weight he lost was...
It's interesting because...
muscle mass.
Because the question really will be, can we put together a true sort of feedback loop between what your testosterone levels are, what your hormone levels in general are, what your lab levels are, what your LDL is, and based on that, give you a cocktail of medicine that can make you look and feel like your best self.
Yeah.
Now, that is the opposite of the world that I think we should go to.
Yeah.
But it's the most likely outcome.
Well, that way you're getting into the world of human optimization. And I think obviously I didn't mean to start here, but we should introduce you, and obviously we'll get into Rezilient. But what we're talking about is first we're treating conditions, chronic conditions. Then we're moving into like actually engineering hormonal health and like optimal human condition, right?
Yeah.
So it's like, let's address problems first. And then like, can we progress towards like actually curating a best version of you physically?
Well, there's one of the biggest, saddest things about America is that a third of kids are already obese.
I know. That's crazy.
It's one of the saddest, we were talking about privileges. Growing up in a family where obesity was not an option was a great privilege, because it was literally off the table, right? Like you played sports, that's what you did. For us, it was because you wanted to get into the best colleges, so you had to play sports because that was our only ticket, really, right? You had to be good at everything. I was joking with, I actually tweeted about this. One of the funniest things is I was talking to my friend Mark, and Mark, I was telling him the story that I got an A- and my parents searched through my room to make sure I wasn't on drugs. And he was like, I can't believe your parents were so upset at you about an A-. And I was like, you shouldn't be surprised that they were upset. You should be surprised I got an A-.
Yeah.
That is unacceptable.
Yeah.
You know what I mean? And it's like this,
so was that intentionally instilled? Because I was having this conversation with somebody the other day. It was a given I was supposed to get A's.
Yes.
But I don't ever remember a moment that somebody told me get A's or else, right? There wasn't a threat of punishment or something being taken away.
Oh, no, there was definitely a threat of
punishment. To me, it was just like there was this implied standard that you were supposed to meet, and I just always did. But I don't know where it came from. I'm trying to figure out.
No, that's good. Yeah, that's a good thing. It came from fear for me.
Okay, yours was fear driven. Okay, yeah, you got this.
It's like the immigrant thing. It's like a very, very different mindset. But it definitely came from fear. It came from fear of disappointing parents, but also came from the fear of not living up to your own potential. You always kind of think about where we come from. I think I told you earlier, but my family, my story all starts with my dad and my mom. Came to this country, worked really, really hard. All three kids went to the best schools in the world. We all worked really, really hard. Dad, was in the garments business. And did everything he could to give us the best life possible. Had access to health insurance, but not good health care. After 20 years of seeing a primary, ended up with a heart attack, which shouldn't ever happen, right? If you have a good primary care provider, you should never end up in that world. But what we found out at the end is that he had sleep apnea. You get 5 minutes with a doc, and they ask you, and my dad, he spoke English, but not incredibly well. And they'd be like, Mohammed, how you doing? Oh, good. Because that was one of the few words that he, would want to say immediately. And then they would just stop there and be like, okay, great. You don't have a problem right now. I've got 10 other people in the waiting room that have problems. Let me go take care of the problems, the pathology, instead of doing any of the stuff that I think we should do. And I was, when he was 53, I was thinking about medicine, and I was becoming an ear, nose, and throat surgeon, at Penn and WashU, and building my own life and my career. And then I see my dad, who worked his entire life, most successful immigrant I know, right? All three, that's what the immigrant dream is. Get them into the best colleges, get them the best life possible, and then never being able to live his dream. And so actually, he got heart failure at 60, became bedbound with heart failure. And then I moved him into my home, became his caregiver while I was becoming a surgeon.
Jeez.
And that experience of going through surgery residency at the same time as being a caregiver is why I built this company.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, 1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has two distinct parts. Number one, to make self-insurance simple and more accessible for small to mid-sized employers. And number two, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale. Well, I mean, I don't have to ask your why after that, but so was there frustration with the system in of itself that you said it should have been caught, right? If he had good primary care, it should have been caught. Was it just a lack of true attention and investigation that you felt was a result of just limited time? Was there the language barrier part of it? Like, where do you think it all comes from?
It was all of it. It's really about this underlying system. The system is broken.
Okay.
The doctors are amazing. You should see what my colleagues are going through. Literally, doctors are quitting at a level you've never seen. And it's not because of the work. I'm telling you, all of that is BS. All of that is out of the administrative class. It's about a moral injury that exists being part of a system that's churning you out and churning patients out.
Yeah. And are we specifically talking to primary care physicians, or are we talking
all physicians?
Okay. Because I mean, primary care physicians are the ones that often are propped up as an example of overwork, underpaid, stress, not fulfilling life. I think the highest suicide rate amongst all.
So physicians in general.
Physicians in general.
On a per capita basis have the highest suicide rate. But I think 400 to 500 a year are taking their lives.
And then, so when you say the system in itself, and that's what we're going to unpack today, and we're going to talk about Rezilient, and what came out, the genesis of what came out of this experience. But structurally, let's talk about some of the components of the system that you feel are broken.
So number one, the payment model is broken. Okay. Fee for service automatically leads to an organization of a system that leads to more utilization because they get paid more for utilization.
Of course.
So the system itself on the business model perspective is broken. Number two is the time spent with the provider. You spend more time with the specialist than you do with the primary. So again, that's because the primary and the contracting of the primary means that the primary actually gets paid less for a visit than the specialist does, right? Like you pay your neurosurgeon for a 30-minute visit way more. In fact, even on your card, it'll say the copay is higher. They're just reminding you this person is more important.
It's more important, yeah.
And every other civilized nation, it's the opposite. Your GP is actually more important to you. You can get a same-day appointment with a GP, or general practitioner is what they call it, in most countries. But it's harder to get a specialist, sure, and that's a problem. But in this country, we've made it hard to get access to a primary. So what do you think everybody's doing? They're going to the urgent care.
Or the ER.
Or the ER.
Yeah.
And so we have fragmented that doctor-patient primary care relationship. That's the second big problem with the system. And I think the third big problem with the system, the one that we really wanted to approach, is that despite every aspect of your life being digital, the doctor-patient interaction is still analog. And they're trying to convince us that it's better analog. Oh, you need the doctor's touch. And I will upset some of my colleagues. Our data shows you do not need the doctor's touch. Some people might want it, but you don't need it. And there's a pretty big difference. And if you can fight that trade-off, a simple example is if you talk to your grandparents, they probably liked going to the bank.
They did.
Right? Going and meeting with the teller, having a relationship with the teller. Oh, Nancy's great. Physical Janet, check. Nice to see you. All that stuff, right? Like physical checks. But like, do you want to see a bank teller now? No, right? Like we've progressed.
If I ever get a physical check, I'm like, thank God I can take a picture of this check and deposit it in my account.
But like healthcare is not like that.
Okay.
Healthcare today, and when I was trained at Penn, one of the things that they would say is, you want to sit down, you want to touch their knee, put their hand on their shoulder, make them feel better, that physical touch, that physical aspect. Do you know if I did that to a patient today that was like in their 30s, what they would say? Like, what are you doing, Doc? And so I think like things are changing, right? And we have to advance with the times. And there's going to be trade-offs. Of course, you're having a tough conversation. There are times when you need to sit down with the patient and have that conversation. But the large majority of those visits don't actually have to be that way. And think about the trade-off, right? So if we can digitize that physical interaction, not just FaceTime, which is what happened during COVID.
Yeah, so not just telehealth.
Not just telehealth. Yeah. So what we built at Rezilient, and the way we're approaching the system is we're saying, let's digitize that doctor-patient interaction, including the physical interaction with our cloud clinics. So you walk into this clinic, the doctors are on the screen, and all the tools in the doctor's office are actually connected to Rezilient and live streaming to the doctor remotely. So you grab the Otis, there's a person in the room, there has to be a human there. We have a ton of data on that.
Is this a physician's assistant, a nurse practitioner? Who's in the room?
We call them presenters.
Okay.
They're paramedics.
Paramedics, okay.
And so they're trained on how to do the physical exam, how to draw labs, how to do basic imaging. They grab the otoscope, they put it in your ear, and your eardrum is streaming live to the doctor.
Okay.
and, eye exam, ear exam, heart exam, lung exam, full body musculoskeletal exam, gait eval, even able to do some ultrasound on site. The ability to do all of that completely remotely unlocks the doctor and gives them superpowers. So now, one, I'm going to say some things that people claim is not true, but it is true.
Okay.
I don't remember, I'm an ear, nose, throat doctor. I don't remember your eardrum from last year. I don't care what people tell you. They don't remember 3,000 eardrums.
You don't look and go, oh, Sally, how
Exactly.
I recognize you.
I remember what your eardrum looks like.
Yeah.
We don't remember any of that. So think about how crazy that is. We don't remember you at all. We look at the note. The note says TM intact, no fluid. So I know what I think I saw last time. But if you saw my dad's doctor's notes, they would never say, I think Muhammad has sleep apnea, but you know what? I'm going to let it go this year.
Yep.
So all of this is getting missed. My co-founder, his mom had heart failure, and they said that she had anxiety. I mean, this kind of stuff happens all the time, right? In healthcare. So what we're doing is...
I know where you're going with this, right? Is once you digitize it, it becomes a permanent asset that's accessible.
Exactly.
Yeah.
So not only for that doctor to look at your ear exam from the year before or listen to your heartbeat from the year before. So let's say you did have a murmur. Because all the devices are connected and live streaming, we can actually record them, keep just the device data, not your interaction with the patient, with the doctor, but your actual device data. So you can take it with you. So you have your own device data. And then also we can hear it year after year. So if I hear a murmur this year, I can be like, oh, I wonder if Spencer had a murmur last year. Let me listen to that. So if I don't hear it last year and I hear it this year, I know that something has changed. Maybe we should get an ultrasound of your heart and make sure that you don't have mitral valve regurg, right? And so the idea here is, by the way, if I then hear that sound, instead of just having that sound for myself, if I want a cardiologist to weigh in, maybe I can second opinion, we can just send it out. And by the way, we do that today. So same day appointments, no copays, no fee for service, as I mentioned to you earlier, but also same day access to consults across 73 specialties in 4 hours. So let's say that you come in, you're having a little bit of chest pain, we're worried about it, but we're not worried that you're having some acute event. So we can do an EKG on site, we can do maybe an ultrasound on site, and we can then take it and send it to a cardiologist. In 4 hours, you'll know what's going on. A diagnosis and treatment plan. And we do that across 73 specialties.
So let's take a step. How would you describe this model, right? Because I think you mentioned fee for service before. Some people might understand that, some people might not. But when you were to present this idea to somebody that's maybe a novice in healthcare or doesn't quite understand what you and I are just talking about, how do you explain it to them in the elevator pitch version of Rezilient? Because let's start there, and I want to build on the experience itself, opening up locations, how it integrates with health plans, et cetera. But let's start with that foundational, what exactly is it?
Yeah, so Rezilient is a new healthcare system for employers.
Okay.
If you were going to build a new healthcare system from the ground up, you would start with primary care.
Absolutely.
And you would start with primary care that's not based on getting paid every time they see the patient. You would base it on a subscription model where you're actually taking care of the patient in between visits too. And so that's what we started with, is an advanced or direct primary care model. That was the first version of Rezilient. We started serving patients 2.5 years ago and serve over 300 employers now in 3 states with physical clinics.
Okay.
And what that means is you as a patient now get access to a primary care provider who's now available to you via messaging, via telehealth, and at the cloud clinics, which are physical locations where the doctors are on the screen. And all the tools are connected to Rezilient and live streaming to your doctor remotely. So once you select a doctor, that doctor is the same doctor for you over time, so continuity of care.
Yes.
And then 2, that doctor's available to you at all the clinics in that city. So, for example, in St. Louis, we have 3 clinics. Those 3 clinics, no matter which clinic you went to, your doctor would see you there.
No kidding. Okay.
Yeah. And then, by the way, if you move from St. Louis to Dallas, the same doctor will see you in Dallas too. Okay. So you no longer have to change doctors as Rezilient continues to grow. Once we figured out that primary care model and added to that, the next layer that we added to it was care coordination. Because really, depending on how your health plan is designed, figuring out who the best doctor to go to, let's say, God forbid, there's something going on and we need a dermatologist, we've got to get you into the right dermatologist.
Yes.
So that care coordination is actually part of our program. So you started with primary care, you added care coordination for referral management, and then now what Rezilient's expanding into is actually building those specialists too. So because the doctor's on the screen, it doesn't just have to be your primary. We can change the device to take care of the specialist. So for a dermatologist, we can add a dermatoscope.
Okay.
And the doctor on the screen can be a dermatologist. So ultimately what we're building into is a digital Kaiser that's available at every location. That's where we're going. And it's really about building this alternative healthcare system that has all the, hopefully, if we can continue to do this, and continue to build what we've been building, has all the right incentives that are aligned with the employer, but even beyond that, aligned with the employee.
Well, I would say aligned with the outcomes we need in the country, right?
Exactly.
Yeah, I think it's what we're really talking. The big picture of this is the financial constraint or strain, if you will, that our healthcare system is putting on our economy.
Yeah.
But one of the things that I wanted to kind of double click on, if you will, is DPC sort of is great in and of itself for a number of reasons, but it doesn't solve every problem. And what you were talking about is like, what if then I need to refer you out, right? So the care coordination component of that. But just because you might have quality data of where the right place to go doesn't necessarily mean we always know how much something costs, right? At least in a normal model, that may not be considered when making that referral. So are you looking at cost in addition to quality for where we're going? And
exactly.
Then how do you quantify if it's good or not, or if it's a quality location?
So there's two big parts. One is clinical outcomes.
Okay.
So you can look at leading metrics for clinical outcomes. You can look at volume of cases. You send somebody to a knee surgeon. If all they do is that type of knee surgery 1,000 times a year, they're probably good at it.
Yep.
But remember, again, the reason why care coordination is important, but not everything, is because yes, we can send them downstream to that orthopedic surgeon, but we all know that orthopedic surgeon has the wrong incentives. Doesn't mean they're a bad doctor. They're probably an incredible doctor, but they have the wrong incentives. And so, one of the things when I was an ear, nose, throat, it's something that doctors are judged on is conversion rate. How many people that are walking into my clinic are rolling into my operating room? So if I'm being judged on that, you give me a metric and I'm a winner, right? A lot of people.
Well, with that conversion rate sounds like you're a salesperson making a close.
Yeah,
that's really what it is. Yeah.
That's literally what it is. And that's, a lot of people don't know, but that's like what we're judged on, RVUs and all these other things. And so that's the problem. The system is the problem. So yes, care coordination is critical. The way we judge them is what's the volume of cases that they've done? What are their outcomes on those cases? What is the experience of the clinic itself? How's the staff? Things like that. A lot of this information is out there, and then claims data on what their actual total cost spend is. And then there's also data from Physician Compare and other places where you can look at infection rates and things like that. So we've actually got partners and also internal data on who the right provider is to send somebody to.
Well, and we were talking over coffee, and we talked about, you mentioned the system a couple of times being broken, right? Or at least I would say the healthcare delivery system is broken. I can make the argument that the insurance side of the equation is exactly how they want it. It's not broken at all. But then it starts to beg the question, can we really even fix the existing version of what we have in healthcare delivery? Or should we be propping up and rebuilding a new alternative system that's over here, that's adjacent, that's offering better outcomes and lower cost, and drawing people to it because market forces are saying this thing over here is better? That's what I'm hearing from you, and that's what I would like to see happen. And I think if you can vertically integrate all the way up the chain, and I don't know where the limitations are. Emergency medicine may be a limitation, right? Maybe not.
Maybe not.
But what I'm hearing is you're almost developing the spine of an alternative system.
So it's interesting because we were talking about this over coffee, but it's interesting that there is this belief that employer-sponsored health insurance is a bad thing. And what I will tell you is that there's no better place to build an alternative health insurance / alternative health care system than the employer space.
I would agree, yeah.
Because if we tried to go to government-sponsored care and do any of the stuff that we're doing, we would be stuck in regulatory capture.
Oh yeah.
And regulatory.
The red tape.
The red tape.
Yeah.
Whereas employers can both focus on their people and focus on costs, which then aligns a very different kind of healthcare system. So yes, that's literally what we're building, is a new healthcare system built with the spine, building the spine on top of primary care. So how do we then go after all the other big claims? MSK, GI, women's health, especially premature birth and perinatal care, maternal care, thinking about GLP-1s and medical weight loss, which is a big issue right now. Thinking about psychiatry and controlled substances and substance abuse, which is another huge shock claim for some employers. And so really thinking about how do we align both the costs and the outcomes, and then do it at the primary care doctor's office. Remember that when we add the GI on the screen, that GI doctor will be at the same place that your primary is, right? So you don't have to like go to 10 different places.
Right.
It's all gonna be coming to you because there's a financial incentive to take care of you, because it's all based on subscription.
Well, see, what you're describing to me is, I don't know if you've ever seen sci-fi movies where somebody goes into a capsule in the future and that capsule like scans them and finds the problem and then fixes it. Like what you're kind of describing me is maybe a step on that direction, but I'm just thinking about the centralization of the individual at the center of this wheel, and you've got all these physicians around it that are multidisciplinary that are able to address the whole person.
By the way, we have models like this. If you go to MD Anderson, right? MD Anderson has multidisciplinary clinic.
Yeah.
If you have some complicated type of cancer, God forbid, they actually bring a team of people to take care of you. But we're only doing it when you're super sick.
When you're super sick. Yeah.
Why don't we do it when you're fine?
When you're healthy? Yeah.
Or just starting to get sick, right? Like why? One of the things that I noticed when I was at WashU, and this is a funny thing, is all the rich people are super healthy. Have you noticed that? It's like this really funny thing. By the way, that's not how it used to be. 200 years ago, that's not the case, right? King Edward was...
It was always, that was a sign of actual wealth to be overweight, right?
Opulence was being overweight and out of shape and having gout and, right? Like that's like how you knew you really made it. Now it's how do you look younger, you feel better, people have, you know what the difference is? Access. That's all it is. Concierge doctors. And so I was sitting there and I was thinking to myself and I was like, okay, so the employers are spending a bunch of money. All their people are still super sick. And then you have this other system that's not even that expensive. I mean, it's expensive, but not that expensive. And all those people are spending less healthcare dollars, right? The average Medicare patient is spending like $1,300 a month or something. Right? Like, think about it. You could just have a concierge doctor for that much. Easy, right? And so I was like, well, what if we just gave people concierge doctors and then saw whether it saved money? The data is that it does save money, not as much as people think. But then when you add on top of that care coordination and add on top of that the specialty care, suddenly we're saving $3 or $4 per dollar.
PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. Well, what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
I mean, it's fascinating because we think about access as patients as doing more. Like they've really done a PSYOP. Like think about how much of a PSYOP that is. Like they've convinced us that the more access is the more they do for you.
Yeah.
When in reality, it's more about how quickly you should be able to get an answer.
Yeah.
Not how much they're doing on your body.
It's access to information, reassurance, and guidance.
Exactly.
Right? That's access.
That's access, not doing more to your body.
Yeah.
What should be happening to your body is that you should be thinking about how do I prevent myself from that? Like, so when was the last time a doctor talked to you about lifestyle modifications? Like, really, does anybody even in this country know what lifestyle modifications means?
No.
But you know how they're like, you just gotta modify your lifestyle. And then your doctor like walks out, has a donut. Like, it's like, that's the reality of healthcare today, which is that we are, talk about root cause medicine. We're not even like, we're not even in the same.
That's not even really taught though in medical school, is it?
No, like I had one, and I went to one, I went to Penn. It's a great med school, one of the best. And I had one nutrition class and it was optional.
I mean, but how's that? I mean, it's hard not to be conspiratorial to think that one class that's optional on nutrition, which is fundamentally what you're feeding your body on a daily basis, that's creating you, right? That's impacting every part of your life. And yet a physician, why are physicians or folks in medical school not trained on nutrition?
Because the best medical schools in the country are not trying to train family medicine doctors. They're trying to train surgeons.
Okay.
Because surgeons are who make the hospitals the most money.
Okay.
The system is built around fee for service. More you do, the bigger the surgery. So you look at any hospital and you see the highest paid people outside of the CEO of the nonprofit hospital. It's cardiac surgeon, plastic surgeon, neurosurgeon, cardiothoracic. And so it's the ortho. And so these folks are the people that are the lifeblood of the current system. And they're really important for the new system. They just can't be the basis of the new system. Like I said, if you were going to build a new system, you'd build it around primary care.
Yeah.
Right? And so...
But I would build it around primary care physicians who understand nutrition, who understand exercise, who actually, sounds like a crazy thought, live out the lifestyle that they would recommend to their patients as well.
And so...
How awesome would it be, and you're a fit guy yourself, but I mean, if every doctor was physically fit, and when they make a recommendation... What's that?
You trust them
You
more.
might trust them, right? That's it. It's a joke, right? But it's the old doctors who used to smoke, right? Or now you have an overweight doctor making recommendations about how you should eat. It's like, why would I take the advice of somebody who doesn't live it out on their own?
Well, so that's one thing that we realize is, so one thing about the Rezilient flywheel is as Rezilient continues to grow, we, as I mentioned, opened 2.5 years ago. We have 20,000 patients now, 300 plus customers, just growing like very rapidly. And as we're doing that, we're hiring more doctors, right? The more doctors we hire, remember they're on the screen. So every doctor is available at every location. So there'll be a day we'll have hundreds of clinics with thousands of doctors where all those doctors are available at each clinic, right? So then you, for example, can go and get a doctor that played soccer like you did.
Yeah.
Right? And you can have that conversation with them being like, soccer knees, and you're actually having, and by the way, that does not exist. How much do people even know about their doctors? This is the funniest part. Like we're going to the nutrition part and we'll talk about that, but like people don't even know about their doctors at all. Like I'd rather have a doctor that actually knows. And, if you have a doctor that focuses on taking care of executives versus a doctor that takes care of people that work with their hands, a doctor that, like, wouldn't you, if you're a carpenter, wouldn't you want a doctor that's a carpenter? Yeah. I mean, like, these are like the funniest matching problems.
I think the simple is like, I was talking to you earlier, I follow mostly a carnivorous diet, so carnivore diet, meat-based diet. There are probably drawbacks, there's downsides, there's trade-offs, I accept those. I would like a physician that understands it, may not even necessarily agree with it, might want to recommend tweaks, but understands that eating protocol. And it would say, okay, well, if that's the protocol you want to follow, then you should be doing X, Y, Z instead, right? Or in addition to that, right? But I don't want a doctor like the one I told you earlier that told me, well, just eat meat like 2 times a week and that'll be better for you. And that
which by the way, was the wrong advice.
That was the extent of the recommendation. And I'm like, I didn't know what he physically looked like, but I'm just
by the way, I wonder which evidence-based randomized control trial he used.
Well, I don't know if he went to that optional nutrition class or not in medical school.
Well, that's the thing. And so taking a step back, why don't they teach nutrition?
Yeah.
They don't teach nutrition because nutrition doesn't make money. That's it.
I believe
it's
you.
Unfortunate.
Yeah.
But they're training us to become revenue generators for the healthcare system. And the best revenue generators for healthcare systems are specialists. That's why when you look, I want everybody that's listening to look at the graduating classes for Harvard, Penn, WashU, Stanford, and see where they're all going and see how many of them are going into primary care and how many of them are becoming, cardiologists, ENTs, interventional radiologists, dermatologists, plastic surgeons. And again, there's nothing wrong with that. We have shortages in every specialty, but we're never going to find systems that are trying to build root cause medicine providers, right? And like healthcare, doctors that are actually practitioners and healthcare practitioners that are focused on root cause medicine. Yeah. It's not what makes money.
Well, yeah, a doctor's not going to recommend that I go get more early morning sunlight on a walk and then sit in a sauna, right?
No.
Like, because they can't refer meet anybody that they can make money.
There's no pill for that.
There's no pill for that. Right?
Yeah. And so
it's
I think
actually literally free to get sunlight, believe
exactly.
it or not.
And by the way, we should all be getting it, especially, interestingly, people of color should actually be getting it more than you, which is fascinating. Oh yeah, because we don't process vitamin D the same way. And so these are the things, again, that the types of physicians that join Rezilient are really interested in a primary care centric or root cause medicine centric relationship with their patients. And somehow when you have superpowers for primary care doctors, same day access to specialists and care coordination, God forbid you have to send them to the regular healthcare system, you send them as little as possible. Suddenly employers start saving a ton of money.
Yeah. Well, that's what we're really getting at. And you were talking about the employer channel, right? So this disagreement, and I would agree with your disagreement that the employer sponsor shouldn't be part of the healthcare chain. I think they should. They're also a massive lever. 165 plus million people get access to health insurance through their employer. That's half the country. So why would we not address that head on? And so then I want to get into the next part of this conversation I think is important. Is we know the insurance consultant, benefits broker, whatever name we want to use, is somewhat of a gatekeeper to access those employers that get you to scale.
Sure.
So how do consultants respond to what you're offering? How do you navigate a conversation with them? Because ultimately they're the ones that are getting you access to most of these employers, right? Or are you going direct?
No, we're working very closely with brokers and consultants.
So that's an important, and I don't use gatekeeper in a negative way either.
No, because the HR person, sometimes, especially if you have 100 to 500 or 100 to 1,000 employees, like you didn't know that you were going to become like an expert in health insurance as like an HR person. That was not like what got into HR, not for benefits design, but because you like taking care of people, similar to doctors. It's kind of interesting. And so you have to hire an expert, a broker, a consultant to help design these models for you. So I will say one of the best parts of our existence has been the fact that brokers, consultants all unequivocally agree that primary care is important. So I don't have to educate them on the we came into a market, and you got to add Rishika at Iora, Amir Rubin and Tom Lee at One Medical. Like those folks deserve a ton of credit because they taught the market that primary care was important. And then they scaled it, or somewhat scaled it, right? Like they started scaling it. I think, so I don't have to explain to a benefits consultant, hey, do you know primary care is important? The part of it that we do have to explain to them is that this version of primary care is superior. And the way you do that is by showing data. So reporting data, care, all of the other stuff that I think, unfortunately, the average mom and pop DPC practice is not doing. That's something that we take a lot of pride in, which is like, look, if you want to treat them like insurance companies, each self-funded employer, you've got to give them data that an insurance company would need to make a good decision. And so we really kind of break out ROI, do $0 claims, give them the claims data, let them do their own analysis. We do ROI analyses for each one of our customers. So it's really leading with data, leading with value. And then once you get them into the primary care system and they see how good the experience is, then and how good the outcomes are, then we can tell them, hey, now that you're doing this with us, we have a bunch of people that are going to an orthopedic surgeon for surgery when we could just put them in an MSK program and get them into physical therapy. And so that's how the flywheel gets going. But to go back to how do you make them change? How do you make them think? You have to remember that the benefits consultant is trying to gain and retain business. And the way that they do that is by providing their employers with better solutions that actually save money. It's time that they actually...
how long of a time horizon should an employer
12 months.
Wait to see the ROI?
12 months.
Okay, so immediate. It's effectively...
It has to be immediate. That's actually... again, I love my DPC colleagues. They have built a system that is actually truly impactful from an access perspective. But this is the challenge with DPC, right? It takes more than 12 months to see savings. That's why the specialty care is so critical, because that's instant savings. You don't go to a specialist, that's a lot of money saved, because if a dermatologist that's a Rezilient dermatologist looks at your mole and says no biopsy needed, you're not going to the outside dermatologist who owns the derm path lab and maybe has an incentive to do a biopsy when may or may not be needed. And so this is one of those things where really there's like instant savings. Whereas with a primary care provider, it's really hard to show what could have happened. With a specialty care, you can show immediately.
Yeah, that's the challenge in the world of like catastrophic risk is like, how do you prove that putting in DPC today staved off a heart attack 4 years from now? You can't really.
And by the way, that employee may not be there for you.
May not be there. The churn question was one that was going to come up next is like, how do you also compel an employer to invest in something like this when they know they might have the employee for 24 months on average or 36 months on average, and you feel like you're investing in somebody that's going to go somewhere else, and that employer is getting the benefit of that improved health. So how do you navigate that maybe objection?
You give them an ROI analysis, and that shows in 12 months they save money.
Okay.
And at this point, what do they have to lose? They're paying 20% year over year, more and more. It's getting out of control. The current system is bleeding them dry.
Yes.
And they have nothing. We're coming in and we're saying, hey, we will do it on a capitated rate. So just unit cost of care will pay for itself. We have that data. So in 1 year, just the visits that you would have done somewhere else will save you enough money to pay for itself.
No kidding.
Yeah.
Okay. Well, so then how do we scale this model, right? Like how do we scale it fast enough? I know obviously you guys had a Series A you closed recently.
Yeah, we just raised a $10 million Series
awesome.
A.
Congratulations.
And interestingly, the approach that we took, look, venture capital is something that is a necessary portion of building a startup that's going to scale at light speed. But finding the right venture capital partners and right investors is really critical. So we didn't go out there and raise a bunch of money from insurance companies and healthcare systems. We went out and we raised money from people that have built companies. So, Rob built Connections and exited, and it's Tim Tebow's fund. Tim is very,
I'm sorry, did you say Tim Tebow?
Yeah, Tim Tebow's fund. Yeah. So, he's obviously very faith oriented, but also very mission oriented. Clint Jones, who started Go Health, took the company public. We've got Mark Jones, who started Goosehead, and took the company public. And so we have people that are doing this. They're patient capital. They want us to do it the right way. It's not just about growing for the sake of growing.
Yeah.
And I think that was really important to us in this fundraise. And so now, and then Jim McKelvey, who founded Square, the payments company.
Yeah.
And so, these are people that have built companies that know how to scale. And so the approach that we're taking is there's two goals with this 10 million. It's to build more clinics so we can serve more patients. And it's to expand services from just primary care to multi-specialty care. So the 5 that we're expanding to in the next 12 to 18 months are GI, medical weight loss, so GLP-1 coverage. We're expanding to psychiatry, so especially like substance abuse, psychiatry, mental health is such a big issue for employers right now. We're expanding to women's health, including maternal health. And then we're expanding to MSK, so back pain, knee pain, and physical therapy. And we're doing that not just virtual, but at the clinic too. So one of the things, a good example is medical weight loss. One of the biggest issues with medical weight loss is you also lose muscle when you get on these GLP-1s. Well, we'll have machines in the clinic where you can actually check your body fat composition and find out how much muscle you lost. So maybe we can increase your strength exercise and keep you from hurting yourself, right? That's something that happens with people on GLP-1s. They get, they can rupture a tendon because they're losing a lot of muscle.
Yeah.
So this is all the stuff that we do that we believe is going to change the way healthcare is delivered. And by the way, none of those are fee for service. Okay. Those are all
encompassing.
Yeah.
Okay. So then what percentage of healthcare services do you think you guys will be able to capture in this model, right? I mean, is this 25, 50%?
No, 80%.
80%.
80% of outpatient care.
Okay, 80%.
And so that's the plan, is to go out there and add specialty. So this is the other big thing that people don't realize. So a lot of people, when they do tech-enabled services, what they do is they take a service model, and then they add technology to it. So think One Medical, for example, right? They are the OG. We would not exist without them. Iora, we would not exist without them. They had a really good service model. You meet the doctor, that doctor spends more time with you, you get same day appointments, and they added their medical record system and they added all these technology on top. And that's called tech-enabled services. But then the best tech-enabled services actually start with the technology. Think like Uber or Airbnb, where the actual interaction is happening through the software, through the experience. And so Rezilient, our cloud clinic virtual care model, you're actually not meeting the doctor in person. The doctor's always digital, right? So when you do that, now you can add specialty after specialty after specialty, and all you're changing is the device in the room and the doctor on the screen. And that means that we can add specialty after specialty. And if you're an employer, now suddenly you don't have to go out there and think about, well, what is going to be my MSK solution? What's going to be my GI solution? What's going to be, there's a lot of point solution fatigue.
You're solving one of the biggest problems when you get more sophisticated at unbundling self-funding, and now you're getting all these things thrown at you that you're trying to plug and play and hope they are interoperable. Most of the time, you struggle with that, right? And if the employer struggles with that, they struggle to communicate it. The employees struggle to understand. Utilization drops or is non-existent, right? So you're solving for that complexity problem by putting it all in one spot.
And it's fascinating. We had a meeting with a Fortune 50, and the CHRO, she told me that they have 20 different digital health apps to download.
I believe it.
And I was like, what's the utilization? Awful.
Yeah.
And I was like, well, I actually couldn't help myself. I said, what were you guys thinking? And she's like, Danish, like people kept on asking and we kept on adding.
Yeah.
And it's like,
well, there's also a mentality of an employer is like, oh, my employees want this. My employees love it. They might hear one person bring it up.
Exactly.
And he's like, oh, of course, yeah, we'll add this to the fold. And nobody uses it.
And there's no ROI.
No.
And so instead of that, what we're saying is you get one solution, one integration, and you only pay for people that use the solution. So then you have nothing to lose, right? So that one person, you only pay for them on the specialty care. Okay. And so that's the approach that we're taking, which is let us take the risk of engagement.
And what should kind of last question, technical question, and then I really want you to talk about what your vision for that alternative system as a whole might look like in the next few years. But what should I expect? We talked about an ROI within 12 months, but what is a reasonable expectation of an ROI in actual quantifiable savings? Yeah. Whether it's a PEPM, PEPY, percentage, like what are you showing? What are you conservatively comfortable with putting out?
If we can get 20 to 30% of employees to actively use Rezilient as their healthcare system, you're saving about 3.25x. So $3.25 for every dollar.
For every dollar spent. Okay. That's significant.
It's very significant.
Yeah.
And we have many.
And you say if we can get 20 to 30, is the resistance just people already have a primary care, or what would make not 70 or 80% use?
At 12 months, we have 20 to 30% using us.
Okay. So you suspect obviously it's going to go up significantly.
Exactly.
I bet, like most things, once an individual within an organization spreads the word about their experience, everybody else wants to do it.
There are so many, every employer knows the influencer in their organization. We always ask that when we get started. We're like, who's the person that we have to convince? And every employer knows that person. They're like, oh, Betsy. Betsy's the one. You got to get Betsy on board. Betsy, man. And so like we actually go and target Betsy, get her into the clinic and give her a great experience. And she tells everybody. Because first of all, Betsy also loves being brought up.
The influencer.
Being the influencer.
But not even just internally. I imagine a person like a persona of Betsy posts about her experience on 100%. Facebook,
or
Instagram,
TikTok.
Or TikTok.
Weirdly, people are TikToking their experience in the clinic.
No kidding.
Oh yeah.
Like actual, like in the clinic.
In the clinic. Because it's so, we know more about our cars than we know about our bodies. The first time you see, let's say you've had ear pain or tinnitus for 5 years, and then you see your eardrum and there's a perforation, you're like, I'm not crazy. This whole time, that's what was going on. Or if you've had chest pain for a long time and doctors are like, oh, you're fine. And then we put an ultrasound on it and it shows like mild regurg. It's like, oh, maybe that's what's going on. And people will start crying. They'll be like, oh my God, I've never seen what the doctor sees or heard what the doctor hears. That's, we talk about the 3 T's at Rezilient. It's time, trust, and transparency. So, really it's the idea that 1, people don't need the doctor's touch. They need the doctor's time. 2, they need a trusting relationship. So complete accountability. This is the weird part. This is the part that nobody tells you, but we know as doctors, which is me telling you something about myself and keeping you accountable for what you're saying. By the way, that's what every relationship is built on, is me sharing and 2, keeping you accountable. suddenly you trust that doctor more. If a doctor is like, hey, Spencer, you need to quit smoking. And like actually takes a moment and says, tell me why you're smoking.
Yeah.
And then you say, well, work's really busy. Okay. But like, think about how much worse it's going to be when you get sick.
Yeah.
I'm going to hold you to that next time. All right. You're going to try to you're doing 20, come down to 10 next time.
Yeah.
And next time you walk in and you're down to 10, you're like, doc, I listened and I'm down to 10. You're like, hell yeah, Spence, let's go.
Yeah.
And so like that, by the way, when's the last time you had a conversation like that with a doctor? Obviously you don't smoke, but like that kind of a conversation with a doctor. Like, when do doctors talk like that?
No, when I told you about my really dissatisfying DPC experience, I wanted to go in and have them, hey, what's going on in your life? How are your kids? Like, are you stressed at work? How are you sleeping? None of those conversations came
crazy.
up. It was really, really disappointing. And so I don't want to take my whole perspective on DPC and have it influenced by, a sample size of 1. I don't. But it was really disappointing because I even was, we have great health insurance at Pareto. They pay for 100% of everything, okay? So it wasn't a financial reason why I didn't have insurance, so I had to do DPC so I get primary care. I wanted it and I wanted firsthand experience, and my firsthand experience was awful. So
we're gonna have to do a follow-up where you go to our clinic.
But that accountability piece is so important. I mean, people will talk about accountability partners all the time. You just tell a buddy, like, hey, dude, I'm trying to do this.
Yeah.
And he's like, dude, let's do it. I mean, I have a buddy that'll call me about once a month. Hey, do you want to do a fast? He's like, I'm thinking about doing a 24-hour fast. Would you do it with me? Sometimes I say yes, sometimes I say no, but he just wants somebody else.
Exactly.
That when we get hungry, that 18th hour in, it's like, dude, are you doing all right? Yeah, I'm good. Are you still good? Cool. Okay. Just knowing that somebody else wants you to succeed or is going to hold you accountable, that's literally all you need to change your behavior.
And I think that we keep talking about how patients are getting sicker. We keep talking about how the system keeps winning and, becoming bigger and bigger. And yet the answer is right in front of us. It's building a transparent relationship where you see everything the doctor sees and the doctor's forced to explain to you what's going on. Your records are available to you at all times. Your imaging is available to you at all times. You know what tasks are being done for you by the healthcare provider on the back end, like when they're like doing referrals for you or whatever. Just complete transparency in everything that's happening to your care. By the way, we expect that with everything that we do today. Like every aspect. Even with your car today, you can go in there and see how the energy in the car is being spread out. I mean, like, there's complete transparency, right? Like, imagine a car that didn't tell you your miles per gallon. I mean, like, this is insanity that people just look in your ear, look away and say, oh, you're fine. You're like, what is going on? And I think that that accountability and that transparency are inherently linked.
Well, that's it. And I think I've talked about this before, but the subject of wearables, right? Like having real time but really useful data that an individual is empowered with to go, oh, wow, my A1C is high right now. Oh, I just ate that candy bar or whatever, right? Like things like that where now you as an individual are monitoring your own health and have data and feedback that it's giving to you. And you know what parameters maybe to look for then to engage a resilient and say, wow, my A1C, or not my A1C, but my blood sugar has been elevated for like 3 days now. Like, is that an issue, right? Or maybe I noticed sleep patterns were disrupted, or maybe my heart rate peaked at some point during sleep, anything. But there's feedback, and it's useful data that I can now come to you as my physician and say, hey, should I worry about this? Right?
So it kind of leads to this broader, what happens next.
Yeah, and that's where I'd like to finish this conversation, if you don't mind.
I think we have this like natural tension today between the analog healthcare system and the digital data that you're collecting. Mm-hmm. And if we can digitize every interaction in healthcare, then your digital data plus that is actually something that we can train a foundational model on.
Okay.
That's where AI becomes really interesting.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
It's very clear that there is this issue between the analog system that exists, which is where you go into a system where the doctor-patient interaction is analog. The doctor then turns around, puts it in the medical record, or there's a scribe that puts it in the medical record, but the actual interaction is not digitized. And your digital wearables, your digital information, your habits, all of that is completely digitized. And so we can't connect those two worlds the way the old healthcare system is set up. But with Rezilient, we have no analog interactions, right? You're going to a physical clinic, but the doctor's on the screen, and that interaction's happening through devices. They're digitizing your eardrum data and sending them to the doctor. They're digitizing your heartbeat and sending them to the doctor. And so really, the basic premise is once both your healthcare data and your personal health data are digitized, now you can connect that data into a continuum. What's happening at visits and what's happening in between visits. And all of that is digitized data. And now that can be fed into a model that can learn about you. No doctor can spend all the time just thinking about Spencer all day, but a model can. We can make a model for Spencer. And that model can be optimized. And we can start thinking about your health as an optimization equation. That doctor made up 2 less meals of meat.
No, he said I only get 2 meals a week of meat.
2 meals a week of meat, which I think the doctor just made up.
Yeah.
I don't know this doctor, but it sounds like they just made it up on the fly. But like, what if that number is, we actually need you to decrease your meat intake after 6 p.m. based on
your data. I love that. Like, hey, based on your average protein intake, let's dial that up 7% or dial it back 6%. Let's add carb here. I mean, if he could get that specific.
That's coming. Yeah. That's what's going to happen. And ultimately, you can see how the doctor or the care provider will know less than the AI.
Okay.
So it becomes a co-pilot for the doctor because the doctor can never ingest all the information. And we are heading to that world in the next decade max.
Okay.
It's coming sooner than people think. I think the more we digitize the data, I'll give you a simple example. At Google, they looked at retinas, and just retina information, they could tell whether somebody had sleep apnea, whether somebody had diabetes, whether somebody had all these other things, but also they could tell whether somebody was biologically male or female. There's not a single doctor in America, the best ophthalmologist in America cannot tell you when they look at a retinal exam whether somebody's a male or a female from the exam.
No kidding.
It can start telling you information that the average doctor could never
perceive. Yeah.
And there's all of this data that's out there that we're not mining. Most retinal exams are not digitized, but they are at Rezilient.
Okay.
Most heart exams are not digitized, but they are at Rezilient. And we have head-to-toe physical exams that we've digitized, provided to the patient, and also keep in a way with that patient's record. And then we can learn from that data and actually provide them with insights about their health. Like there was a study recently that looked at eardrums, and they were looking at eardrum data, and they were like, oh, we can tell from the vascularity of your eardrum whether you have sleep apnea or not, for example, or whether you have other issues or not. And so what if all of this data could give us insights that the average doctor could never catch? And it's not a knock on doctors. I am one. It's just, we're humans.
Yeah.
The average human would never catch
You're
it.
talking about optimization, but what it also solves for is the I feel fine syndrome. And then all of a sudden, I had a physician on here that had 3 of his patients, unfortunately, have heart attacks in one summer while he was practicing and pass away. And it was that fear of, how did I not catch this? How did I not see it? How, looking for anomalies. Let's say I'm, a couple years, I'm 45, I still feel like I'm doing great, but all of a sudden there's a little thing off. If the digital footprint or the digital shadow of me could detect some anomaly that needs to be detected and looked at early to prevent something catastrophic from happening, I might feel fine. I might feel great. I might feel like I'm thriving, but there was something off in the data that signaled you need to have an intervention.
And that's the thing, is that accountability.
Before it happens, though, before it becomes the widowmaker heart attack and things like that, right?
Or when it's sleep apnea and not heart disease.
Yeah.
Right? Like my dad. And so one of the things that's interesting is that the role of the doctor is going to change. We will not be the smartest person in the room, even if we think we are, right? It's just the role of the doctor is going to be that accountability buddy. The person that's actually going to have a relationship with you. The person that's actually going to build that, you were talking about you go into a pod and all this stuff happens to you. that reality is far away. There's a much closer reality, which is that there is a system that is helping the doctor make the best decision for you. And it's the job of the doctor to actually make that behavior change happen.
Yeah.
Isn't that funny? Because that is not what doctors are doing today.
Yeah.
What doctors are doing today is they are the robot, not the person. They are the person that's saying, they are the robot that's saying, you need to do this A, B, C, and D. But then we forgot the humanity portion. Mm-hmm. And interestingly, that I'm very convinced that AI will help restore the humanity in the doctor-patient relationship.
Well, the simple example is if I'm spending most of the time looking down at a notepad and drafting notes and updating them for this visit, did I ever look you in the eye? Did I ever talk to you? Did I ever actually make a connection with you, right? And so if you remove the necessity of just something like transcribing your notes, now you and I are just talking face to face. And I know as a physician, when I refer back to my notes later, they've all been digitized and I can review them and I've got a digital, visual of the eardrum or whatever it may be. The whole time I'm just talking to you.
Exactly.
There's a connection there.
And how do you build trust? You build trust with a connection, with all of these parts of the doctor-patient interaction that people never think about. It's not about just touching your shoulder, right? It's about giving you the time, answering your questions, explaining to you what's going on with your own body, and actually addressing your concerns. And I think that, and not looking away, right?
Yeah,
actually looking at you while we're talking. And I think that is the funniest part of what's happened with Rezilient is that we have, if you look at online reviews, our net promoter score is 90. People are coming to physical clinics where the doctors are on the screen and they're saying it's better than a normal doctor's office. It's just because we are focusing on the things that actually matter for patients.
Yeah. Well, so last question for you, and then we'll kind of finish up, and I know you've got to travel ahead of you. What does success look like for you? Like define real, true success when it comes to Rezilient.
So for us, it's very clear, is that we want to build the largest healthcare system in America.
Okay.
Healthcare systems are inherently difficult to scale because they're regional, they're local. And for us, because our doctors are spread across all the locations, we can both be local and regional and national, right? Because the doctors would then be spread across all the locations. Yeah. And so it's really about becoming the next big change that happens in the healthcare system and to expand across every specialty. So the very simply a full healthcare system where every doctor of every specialty is available at every location. So you don't have to go to 10 different places. You don't have anywhere to navigate. It all comes to you, and we can do this at scale. I mentioned this to you before. DPC is great. Again, we would not exist without that. But today, if you took all the DPC doctors in America and put them together, they're smaller than one of the larger healthcare systems. And so we really have a lot of work to do, and we can't do it without the employers and the consultants and brokers that represent them and all the other partners in the ecosystem to say, hey, is this actually the solution? Because like I said, there's nothing to lose. The other healthcare system is absolutely awful.
We're already losing.
We're already losing.
We're already losing for sure, man. And so is there a number in your head of a number of members, a size, maybe a geography reach that you'd have that you feel like you've quote unquote hit critical mass or a saturation point with that business?
Yeah, I mean, we talk a lot about the 10 million lives number.
Okay.
And it's a very aggressive number.
Yeah.
But that's how this goes. You scale very, very quickly once you get to critical mass. And so for us, if we can get 10 million people into a new healthcare system that actually thinks about them not as a revenue stream,
not a commodity,
I think we will have made the real impact that we're hoping for.
Dude. Well, I love it, man. I mean, I'm glad we sat down because you and I had a very brief conversation, and I knew, obviously, by extension, with the relationship with Adam Berkowitz, that you were onto something, right? The hour and a half, 2 hours I spent with you, I'm even more convinced is that the case, man. So I wish you best of luck. I know you got stuff to do after this, man. And I can't wait to catch up in 6 months, 12 months, and see how big you guys have gotten.
Appreciate it, man. Thanks for having me.
My pleasure.